Hello, and welcome to our survivorship panel called 50 Years of Life-Changing Care. My name is Dr. Stephen Paterno. I'm the Deputy Director of the Duke Cancer Institute, and I'll be hosting our panel this afternoon. Before we get started with the introduction of our panelists and some opening remarks, a few friendly reminders about our webinar. First, today's event will be recorded. We invite you to submit questions during today's discussion through the Q&A tab on your Zoom. We will do our best to answer your questions throughout the presentation. And then finally, if needed, a live transcript of this event is now available, an available option, and may be turned off or on by selecting the closed caption or live transcript option from the menu at the bottom of your screen. So thank you to everyone for joining us today. And I'd like to just provide a few introductory comments, and then I'll introduce our panel and start off with some of the questions that we've already received. Well, I'm delighted to be here. Survivorship Day is a huge celebration of our survivors, those who support supportive individuals and families facing cancer, and to inspire the newly diagnosed patients that we're working with right now. I also want to extend an appreciation to our healthcare heroes, who even in the face of a global pandemic have strived to provide seamless, outstanding care for all of our patients and families. Here at Duke, we've had a long history of providing exceptional and comprehensive cancer care. In fact, this year marks the Duke Cancer Institute's 50th anniversary as one of the original 8 National Cancer Institute designated comprehensive cancer centers. The NCI Cancer Centers program was launched in 1972, just subsequent to President Richard Nixon launching the War on Cancer and signing the National Cancer Institute of 1971. But cancer care at Duke, similar to the National Cancer Institute itself, actually dates back to the 1930s, with the opening of the Duke University Hospital in 1930, the signing of the National Cancer Act of 1937 by President Franklin Roosevelt, which created the National Cancer Institute, and the 1937 opening of the Duke Brain Tumor Program. So we are actually talking about over 80 years of continuity of care, research, education, and training the next generation of providers and cancer research scientists. But more than just a timeline, it reminds us of our commitment to the continuity of cancer care for each individual patient and their families, with patient-centered care as our highest priority. This means working tirelessly to improve, and it means creating a seamless intersection between community outreach, screening, and diagnosis, between Duke primary care and Duke cancer care, between the surgical, medical, radiation, transplant, and immunotherapy treatment teams, and between cancer treatment and our spectacular, nationally recognized supportive care and survivorship programs for patients, excuse me, caregivers, and their families. And we do all of this with an intense focus on achieving cancer health equity, providing top quality cancer care for all of our patients and for all of our communities. So it's with great pleasure today that I introduce to you our distinguished panel of experts. First, excuse me, Dr. Kevin Effinger is a family physician, founding director of the Duke Center for Oncoprimary Care and the Supportive Care and Survivorship Center at the Duke Cancer Institute. He is a professor in the Department of Medicine at the Duke University Medical Center. Dr. Effinger has a long-standing record of NIH-supported research in cancer screening and survivorship, and has served in a leadership capacity in various cancer-focused, primary care-focused national committees and organizations. Dr. Cheyenne Corbett, well known to so many of you, is the co-director for Supportive Care and Survivorship Center and for the Onco Primary Care Center. Dr. Corbett is a licensed marriage and family therapist with an area of clinical expertise in the psychosocial support of patients diagnosed with cancer and their families. Her research involves learning about cancer's impact, how it impacts patients and family members, and their relationships. She leads a multidisciplinary psychosocial team comprised of clinicians and researchers, including medical family therapists, oncology recreation therapists, child life therapists, patient navigators, and psychologists. Dr. Corbett's team also consists of additional members who coordinate volunteer services, self-image programs, and external relations. And she has helped design and oversee a psychosocial oncology training program for master's and doctoral students that prepares these clinicians and researchers for careers in psychosocial oncology. Dr. Carrie Anders is the interim division chief of our Division of Medical Oncology, the medical director of the Duke Center for Brain and Spine Metastases, and a translating Duke Health scholar. Dr. Anders is a leading expert in the clinical care of patients with breast cancer of all stages, with a research focus in breast cancer that spreads to the central nervous system. In her role at Duke, her clinical and research focus has been on brain metastases arising from all solid tumor types, alongside a state-of-the-art multidisciplinary team. Alicia Johnson is a nurse practitioner with clinical expertise in breast oncology. She is a practicing nurse navigator at the Duke Women's Cancer Center in Raleigh, and in her role, she is the middlewoman between the patient and clinical care staff. She navigates patients through the treatment process by connecting them to the resources and the information they need to make informed decisions. A nurse navigator assists the patient from initial diagnosis to end-of-life treatment if necessary. We are fortunate today to have such a distinguished panel of talented experts. So I'd like to start today by asking a question to all of our panelists to give each of you a chance to respond from your particular domains of expertise. And the question is this: we have seen the cancer landscape change significantly for the better part of the last 50 years. Would you share a major advancement that you feel has changed the face of cancer care? So, Alicia Johnson, let's start with you.
Hi, thanks. So, one thing that we've recently been doing at Duke for all of DCI is a pilot using e-communications or e-consults for the emergency room and primary care doctors who have a patient who they're concerned about having a new cancer problem, say a pelvic mass. And this is a great thing that helps expedite getting patients both the workup that they need and into the clinics quicker to a diagnosis. This utilizes the nurse practitioners and the physician assistants in those clinics to evaluate those patient referrals prior to arriving, which I think has been really helpful.
That's great. Dr. Anders?
Sure. So gosh, it's hard to decide what to choose because we've seen so many advances, but I think the one I'd like to highlight today is that of tumor sequencing. When I think back to nearly 2 decades ago when I was in my training, the amount of information I had about an individual tumor was so limited compared to the information that I currently have in the clinic. And that really comes from looking at the genes and the alterations in the genes in the tumors themselves, as well as sometimes tumor cells circulating in the blood. And having that information in hand has been just extraordinary in terms of how we tailor our treatments to our patients. And I've really loved the program that's been developed at the Duke Cancer Institute, the Molecular Registry of Tumors, that really helps facilitate clinical care and then also research in the way that we take care of patients with cancer.
Dr. Effinger.
So it's breathtaking. Think of all of the new targeted therapies that have come into play in the last 10 years. But the area that's been most impressive to me are changes in delivery of radiation. We still need radiation for so many of our cancers, both for curative therapy as well as for palliative treatment. Radiation came into in 1940s for some of our rare eye tumors and some other cancers over that time. And to go from that time period to this time period and see the ability to really focus the radiation and reduce the amount of radiation to the normal tissue around that area and be able to treat the cancer, but also not impact normal organ function afterwards, has been an incredible feat.
And Dr. Corbett.
Thank you. Yes, for me, one of the biggest shifts is in the recognition and importance of behavioral and relational care during cancer treatment, survivorship, and those facing end of life. This change in focus acknowledges the impact of all the ways that cancer impacts the lives of patients and their loved ones, and the importance of offering services and resources to support people as they go through their cancer. And so for me, when you look at the field and the work that we're doing here at Duke, there's more and more research to support that when we help patients and their loved ones through their cancer, whether it's helping cope with the changes in their life, their relationships, or their body, whether it's supporting communication in the family or with their healthcare team, or whether it's attending to practical challenges like the financial implications of going through treatment, we know that these interventions that we offer really help people participate in the medical care that they need. And as a result, you can have better quality of life and even better clinical outcomes for your treatments. And so for me and our team, the cancer care model that we have at the Duke Cancer Institute that combines this medical care and the psychosocial care is a critical advancement in the last 50 years, and one that we continue to lead the way with here at DCI.
Thank you. That's terrific. So the next question is open to all of you. What does the future of cancer detection and treatment look like? And Dr. Effinger, I wonder if you might also comment on this new term that has been making a lot of attention lately, this concept of early cancer interception.
I'd be glad to. Thanks so much. You know, for, oh gosh, going on 3 decades, we've basically had only 5 cancers we could screen for. Breast cancer, colon cancer, prostate cancer, cervical cancer, and then more recently, lung cancer. And so many other cancers we've not had adequate ability to screen for, or even to be able to act upon before they become invasive. Over the last 10 years or so, technology has really developed to what Dr. Andrews said a moment ago, is that we can take circulating tumor cells or even mutations of cells in the blood. So you can draw blood from somebody, be able to identify cancer. We'll be one of the centers starting with a study called Pathfinder 2 in the next couple of months, where there is a blood test that has a detection for about 26 different cancers. And that's a major, major move towards where we were 5 or 10 years ago. Along that lines, we can identify sometimes the mutations that we may be able to use low doses of targeted therapy, not to treat the cancer, but to prevent it from occurring in the first place. So a very exciting time in the next 10 to 15 years in cancer detection.
And Dr. Anders, would you care to comment on the future of cancer treatment?
Sure. So lots of new directions, much of which is rooted in our deeper understanding of the biology of cancer and really being able to identify genetic alterations that could potentially be the Achilles heel. The other direction that we'll be speaking about will also be immunotherapy, which is essentially turning the immune system and an individual's own immune system against a cancer in their body. So I think we're getting much more precise, and we're also using our own bodies and our immune system to be able to sustain responses over time.
And Cheyenne and Alicia, would you like to comment on the role of supportive care and patient navigation in the future of cancer care as well?
Yeah, I'd love to comment on that. So, I think navigation is an up and coming thing that we've been utilizing more and more in cancer care. And I think it really improves both the support that patients feel and the expediting their care throughout their cancer process. In nursing navigation, typically we have a big role in helping people get into the system and then helping them get throughout the system, and communicating with, all their collaborating physicians. And I think it really helps to educate the patient and give that patient, kind of this hand-holding experience that makes you feel more comfortable.
Yeah, and to go along with what everybody's saying, I think as we think about detecting cancers earlier and being able to treat cancers earlier, for me, it's also the importance of detecting stressors and barriers that patients experience so that we can be actively communicating with them throughout the phases of their cancer experience and connecting them to much needed resources or services to help them through, and shifting from, rather than being reactionary once something becomes so big or challenging that it's hard to manage, intervening with our patients and our other care team members much earlier, so that we can really help prevent or reduce challenges that patients are facing. And I think that is going to be really critical for us as we keep going forward.
Thank you, Dr. Corbett. We have a very specific question for you. I have started chemo and I am seeing the effects on my appearance. I am losing my hair. I haven't told anyone about my diagnosis. My kids are 10 and 4, and they're starting to ask questions. I want to tell them, but I don't know how. Do you have any suggestions?
Yeah, thank you for sharing that question, because that's actually one of the, a very common question that we hear about how to talk to your children about your cancer diagnosis and your treatment and the changes that you're experiencing physically, emotionally, and the things that are happening in your family. So because of this, we actually created a role at the Duke Cancer Institute that actually is focused on providing education and support to parents facing cancer. So our child life specialists can talk with patients about their questions, their treatment, their kids, and provide you with education on how to talk about these very complex topics like chemotherapy and side effects, and how to answer questions about them. Because even as adults, these are concepts that are very difficult to understand, let alone thinking about how do you explain that to children and children of different ages. So we think it's really important to talk within your family about cancer and the changes that you'll be experiencing, but utilizing age appropriate or developmentally appropriate language. So open, honest communication that's age appropriate is really important. But knowing what that looks like can be challenging. So that's conversations with our team members, like our child life specialists, can help parents find those words and find words and ways to talk about it within your family that really fits with you and what you're experiencing, because we know it can be really scary and confusing, and for kids, because if they don't know what's going on but they see changes happening, it is really important that you are asking this question and seeking resources to help support you. So in addition to our child life specialist services that can provide individualized education and for you about how to talk to your family. They also have educational materials that they can share with you. And we also have support groups that we offer that are specifically focused on families facing cancer. So we have a group called Kids Can that is for kids who have a parent with cancer, so they can talk with other kids who are also similar age to them to learn about what cancer is and how to deal with the changes that you're experiencing in your family. And we also actually have a parenting group that you'd be able to attend where you can also talk with other parents about what it's like to be parenting while also facing cancer. So these are really important questions, and it's important as you're asking these questions and seeking these resources so you can have these timely conversations within your family and help support your kids. And actually, Dr. Patino, we have a session later today that's focused specifically on parenting with cancer. So if anybody is interested in attending that, I believe it's at 1:30 today.
Thank you, Dr. Corbett. It's really great to hear of all the services, support services that DCI is providing for people struggling with these kinds of questions. Dr. Anders, a few minutes ago, you mentioned immunotherapy and you made a brief comment about it. We have a question. What is immunotherapy? Can people choose to have either chemotherapy or immunotherapy, or do they work together?
That's a great question. So chemotherapy effectively damages all cells in the body. It doesn't necessarily target cancer cells. It impacts cancer cells more than normal cells because cancer cells divide rapidly. So, you can think of chemotherapy as a therapy that is a little, it's not targeted. It does impact the cancer cells clearly, but not in a targeted specific manner. And it also impacts other cells in the body. And that's where we see many of the side effects from chemotherapy, whether or not it's the hair loss we've just discussed or impact on the bone marrow and the blood cells that our bodies make. Immunotherapy is quite different. And I mentioned earlier that immunotherapy essentially helps turn the immune system against cancer cells. And we have checks and balances ongoing in our bodies as we're all sitting here today that keep our immune system in check. And effectively what immunotherapy does is it releases the brakes on the immune system to allow the immune system to fight the cancer cells. Currently, the immunotherapies that we have in the clinic are relatively non-specific, but we're working toward making immunotherapy more specific to individual cancer cells. So we're very excited about that prospect. So to your question about who is appropriate for chemotherapy or immunotherapy or both, that's very tumor specific. And sometimes it's biomarker driven. So does the cancer cell express a marker? And the one that I will comment on is PD-L1 that indicates that immunotherapy would work well or work better in that tumor. So in some cases, PD-L1 expression is not needed, but in some cases it is. In general, we tend to give immunotherapy with chemotherapy, but we also have strategies where we give immunotherapy alone. So much of this is very dependent on the tumor type, the individual characteristics of the tumor. And is, I would always encourage to have these conversations with your physician to understand why those choices are being made.
Thank you. That helps clarify things, even for someone like me who hears this information all the time. Dr. Effinger, we have a question that says, how have clinical trials advanced over the last 50 years? I know that's a huge question, but perhaps you and Dr. Anders could just make a couple of comments from your observations having been involved in clinical trials over several decades?
Certainly. That's going to be more appropriate for Dr. Andrews, but I'll answer it in a couple ways. Clinical trials started back in the 1960s with pediatric cancer. First cancer that was really tested was Wilms tumor. And the clinical trials became the cornerstone of understanding what your best therapy is and if you thought you could improve it a bit more. And so you put people randomly into one of those two groups, what we consider as our standard of care and what we hope it improves care with that. About 90% of kids that are treated with cancer are treated on a clinical trial to really advance the care of pediatric cancer tremendously over the last 3-4 decades, where now our overall cure rates for pediatric cancers are around 84-85%. The number of adults that go on to clinical trials is much, much lower, both adults that are older as well as our young adults. And it's really key to be able to advance science, give the best care we can is through clinical trials. I'll really hand that off to Dr. Anders to be able to expand upon.
No, I think that's a wonderful point, Dr. Effinger, in that, you know, my hope over the course of my career is to see the number of adults with cancer on clinical trials increase over time, because essentially that's the way we make new discoveries. That's the way we ultimately move the needle forward. You know, thinking back over my 2 decades in practice, what I have seen with regards to clinical trials is increased inclusivity. So what I mean by that is that many times the criteria to go onto a clinical trial involve trying to capture a unicorn. And we know that there aren't many unicorns. And what we want is for our therapies, the knowledge that we learn from a clinical trial to be applicable to all of our patients, all ages, different medical comorbidities or medical illnesses, different stages in their disease, different locations of their tumors. So, you know, this is something that we've seen from our governing bodies like the National Cancer Institute, the American Society of Clinical Oncology, is to ensure that our clinical trials are reflective of the patients that we see in our clinic. And that means that we need to loosen the criteria of the clinical trials. We need to make certain that we're thinking hard about why would an individual patient not be eligible for a clinical trial? You know, Dr. Paterno indicated that my clinical research interest is in the setting of cancer that metastasizes to the brain. And when I started down this path over 15 years ago, a history of brain metastasis was a clinical trial exclusion across the board. And now we're seeing clinical trials dedicated to patients whose disease has recurred in their brain. So that's a really nice example of how we're seeing the results of our clinical trials being more applicable to our patients in the clinic.
That's great. And I think I'd also like to add to that, that we are seeing an increasing focus on diversification of participation in clinical trials. One of the most challenging and disappointing aspects of clinical trials are, number one, how few patients of our total patients actually participate. But even more than that, how few patients from minoritized or marginalized populations are enrolled in clinical trials. That difficulty is caused by a constellation of a lot of complicated things, including medical mistrust based on historical atrocities, but also oftentimes simply not being asked to participate because of either implicit bias or even structural racism still embedded in our health system. And I think one of the things that we have done at the Duke Cancer Institute is take that problem on really without flinching, and have moved to try to be equitable in our clinical trial enrollments, so that our patients enrolled not only look like our patient population from their tumor characteristics, but look like our patient population and our community population from their racial and ethnic and other demographic characteristics as well. Dr. Effinger, I'm going to return to you with a question that I know is right in the middle of your ballpark, if you will. I have finished my treatment. How will my care change?
Great question. If we look at things traditionally, 20 years ago, 10 years ago, 15 years ago, patients would continue to be followed by their oncologist or their surgeon for years and years and years. And sometimes also had a parallel follow-up with their primary care provider. What we realize is that now with our cure rates so good in so many of our cancers, breast cancer, we're around 86, 87% cure rates. Testicular cancer, we're around 97, 98% cure rates. Some cancers that were above 80, 90% cure rates, a patient's more likely to die of a heart attack or a stroke than of their original cancer, or even have a second cancer that might be genetic in nature or related to our treatments or related to lifestyles that led to the first cancer. And what we've realized is that when we have these two siloed types of care between the oncology team and the primary care team without good, adequate communication, we do disservice to the patient. And we lose opportunities. We cure the cancer, but we lose the patient. And so we've been working at Duke really trying to connect our primary care providers and our oncology providers across the cancer continuum, from prevention, screening, but certainly during and after the cancer care. Dr. Andrews has talked about metastatic breast cancer. Metastatic breast cancer is very different now than it was 20 years ago. We have patients that are living 15, 20 years with metastatic disease. Chronic lymphocytic leukemia. It's a chronic cancer we can't cure. We have patients that can live 15, 20, 25 years with our therapy. And it's so key during that time that our oncology providers and our primary care providers are working together, not only to either cure or control the cancer, but also to make sure that the heart disease or other health problems are managed in an appropriate way.
And Dr. Anders, a question just came in, and it's related to what Dr. Effinger just said. Some doctors approach metastatic disease as a chronic condition. What are, if any, the new approaches in the treatment of metastatic breast cancer? And then Alicia, I'd like to have you follow up with that, how you address those kinds of issues with your patients as a nurse navigator.
Sure. So as we approach a patient for a treatment plan with metastatic breast cancer, there are multiple variables to consider. One of the key advances has been the subtype of the breast cancer. Is estrogen receptor positivity seen? Is HER2 positivity seen? Does the tumor lack all three, estrogen, progesterone, and HER2, for what we call triple negative breast cancer? So that information is so key to develop a treatment and a maintenance plan. We're now also looking at the genetics. What genes were inherited by a patient? Was the BRCA gene altered at birth? And is that a way that we can target the cancer cells through a class of drugs called PARP inhibitors? So, I think not to get into too many details on all the different treatment pathways, but one of the first things as you're talking with the patient is to really establish what type, just as Dr. Effinger was saying, metastatic breast cancer is multiple disease types under one umbrella. So really important to understand what pathway we're going to go down, and then really work with each individual patient to understand what treatment is going to work best for them in that moment in time. That might be the difference between an oral therapy or an intravenous therapy, depending on other, what else is going on in their life at that time. It may be whether or not hair loss is an important component to each individual patient. So, you know, I think that's where I think the art of medicine is partnered with the science. So I think, you know, the goal in making those decisions is that not only do we treat the cancer up front, but maintain that response for as long as we can, for as well as we can. So I know that's a bit of a long-winded answer, and I'd love to hear Alicia's comments as well. But I think that, you know, that is the joy of working with each individual patient to come up with the right treatment and maintenance plan for them.
I love that, Dr. Anders. You know, you touched on a lot of things that I think are really important. I actually have a passion for this kind of patient, is the patient that we are treating like a chronic illness. And individualizing care is one of the most important things that we try to do, and establishing what is this patient's goal in receiving care, and kind of creating a situation that allows them to be the driver of the bus, tell us what it is that they want to achieve, and make sure that we're supporting them with the treatment plan we create. And that includes, you know, connecting them with support groups and, you know, community resources and things like that as well, that help make this a chronic illness that they can have good quality of life with.
Thank you both. Dr. Corbett, a question for you. Both my family and I have anxiety about my cancer coming back. Do you have any suggestions?
Thank you. Yes, absolutely. And first, I want to start by saying that that is totally normal. I think every single person who has gone through cancer has those worries and fears once they're completed treatment. And so I think some of the things that we've talked about today are some of the best ways to help address that anxiety, because, you know, concerns about your a cancer recurrence will happen. They will be on your mind. Sometimes that increases as you're approaching timeframes like medical appointments around scans or lab work. And so to know that those changes are normal, and the reality is it's probably never going to be zero anxiety or zero fear, so that's also okay and totally normal. And you'll see these increases at different times. And when you feel like you are starting to maybe not have as much control over that as you would prefer, or if you feel like it's impacting your day-to-day life, there are resources available to help support you with how to manage that anxiety, how to lessen that anxiety, and how to understand how much is normal or how much, you know, you might need a little bit of help with to help you cope with those ongoing fears. And we have some terrific resources available. The other thing that can be really helpful is having a plan in place. So much like when you're going through treatment, you have a plan, you know what to expect, you know when things are going to happen and which team member you're working with. During survivorship, it's very similar in setting up essentially your survivorship plan with your oncologist, with your primary care provider, and really knowing then what your follow-up care should be, when you would be having appropriate screenings or visits with your doctor, so that you can have that same level of preparation and planning in the survivorship phase as you did during your treatment phase. So consulting with our survivorship clinicians or your oncologist or other behavioral health clinicians can be really important to set up that plan for yourself to help work with those worries after you're completed your treatment.
Dr. Anders and Dr. Corbett, I'd like to get both of your responses to the following question. I was treated at Duke some years ago, and my doctor never talked about treatment affecting my sexual function. Is that the norm, or have things changed?
So I can start with that one, Dr. Paterno. So particularly, well, I think across all solid tumor types, impact of cancer care can certainly impact sexual function. And this is something that we welcome conversation about. There's no reason to be shy about this conversation. I know in the breast oncology clinic, where we're utilizing many therapies that impact estrogen. Certainly there's going to be an impact on sexual function. Same is true in our prostate cancer population where we're impacting androgens. So it is something that we're very open to talk about and would welcome the conversation. The good news is, and this is where I'll turn over to Dr. Corbett a little bit, is that we have resources. And in my own practice, I partner quite a bit with our GYN colleagues, particularly to find solutions that are non-estrogen containing to really help preserve quality of life and sexual function, but not impacting cancer recurrence risk. And I'll turn over to Dr. Corbett to talk a little bit about what the DCI has also put into place to help support sexual function after cancer care.
Thanks, Dr. Anders. Yes, I would say that we're definitely changing our response to this. I think in the past, oftentimes the conversations with oncologists were very focused, of course, on treatment and treatment side effects, but then the ripple effect that then has on your life and the changes that you're experiencing, we're doing a lot now to continue to make sure we're having those conversations and normalizing, recognizing that a cancer treatment, cancer itself, cancer treatment has this ripple effect on your life. And so we want to make sure we're talking about these things with patients because it's very important in terms of patients' quality of life and their experience as they go through treatment and beyond. And I would say in addition to physical changes that people might experience that might affect their sexual health and intimacy, stress and other emotional changes, they also affect sexual health, intimacy, partner relationships, communication. So we take sort of an approach like we do in a lot of our services that's really systemic and really looking at what is the impact that you're experiencing and who are the best people to help you with that. So we actually have set up a sexual health and intimacy program that really addresses this. And again, and I know I say the word normalize a lot, but really normalizes that this is something that you may experience and we want to talk to you about this. And we do have services and resources to assist. So with our sexual health clinics, we have specific clinics that are set up with experts in helping to understand the changes that you might be experiencing and the treatment of those changes. That includes physician, physical therapist, medical family therapist with a very specialized multidisciplinary clinic. And in addition to that, we also have medical family therapists and clinical psychologists who are trained in sexual health and intimacy work who can provide sex therapy and relationship therapy as well. And so we, in addition to that, as I mentioned, we also have different educational sessions. So there's a lot of resources available to help patients. And the key is exactly this, asking about resources and sharing and communicating with your oncologist or your primary care provider or your survivorship specialist so that they can connect you with the appropriate resources with the expertise of how a cancer and cancer treatment might affect this realm of your life. And so happy to say that we've got a lot of resources now to help support patients.
That's very exciting. Thank you for updating us on that. Dr. Evinger, a question about genetic testing came in. I have been reading a lot about genetic testing in the news. I had my testing done 18 years ago. Should I get tested again?
Great question. It comes up a lot. 15, 20 years ago, we often would test for very specific mutations. Dr. Anders mentioned the BRCA mutation earlier. So sometimes for young women with breast cancer, we would check for BRCA1 or 2 mutation, but not a full panel. Nowadays, more times than not, we actually have a full panel of cancers that we look for mutations associated with it. We recognize that about 10% of people have a gene mutation when they have advanced cancer. 5% of them, or half of those, are the driver for the cancer they experience, but 5% are for another cancer. It's important both for them or for their family members. We have a wonderful genetic counseling team. And what we recommend is that when that question comes up, we refer our patients to our genetic counselors. They'll look into the testing that was done previously. They'll talk about what advances may have been made, what additional benefits there might be for further testing.
Thank you. And one of the issues that has come up over the last 2 years during a global pandemic is about cancer screening. And have we seen drop-offs in cancer screening? And if we have, what might be the impact of that? And that's for, I would say, anyone, but probably Dr. Effinger and Dr. Anders.
Yeah, I'll jump right in. Yes, we've seen a dramatic drop off in cancer screening, both at Duke, North Carolina, and across the US and worldwide. And we've started to see what we consider to be a stage shift, meaning patients coming in with more advanced disease than we did 3 or 4 years ago. It's essential that we again keep up with our screening, both our primary care providers encouraging our patients to get in and talking about the risks and benefits thereof, as well as our patients that have gone through cancer therapy and the surveillance that we might have for following for cancer recurrence.
No, I would just echo those thoughts and comments, Dr. Effinger. I think we've all just been trying to survive the global pandemic, and effectively, for several weeks to months, many of our screening procedures were effectively closed. And I think we're very happy to say that screening is happening again, but we want to pick it back up to the rate that it was pre-pandemic. I think we've also learned a tremendous amount about screening post-COVID, and particularly in the breast screening domain. We know the vaccine can impact lymph nodes that may be detected on mammography. So it's really important to discuss timing of COVID vaccinations and mammography. And there should be questions that are asked now that we know that we can see changes on mammogram that are related to the vaccine, not to a new cancer. So just really, we've just learned a tremendous amount very quickly, but I think we're all, hopeful that we can get back to the rates of screening pre-pandemic, so that we can move that stage shift back to the earlier stage diagnoses for all the wonderful reasons, so we can provide the care in curative intent.
Yeah, Steve, if okay with you, I'll jump in and add a plug for Duke Primary Care Network. The primary care providers have a dashboard. They can look at any point in time on whether their patients have had their diabetes checks, their statin, their cholesterol check, things of that nature. And they track each of our different cancers that we screen for. And they know the percentage of their patients that are not up to date with screening, and they have ways to be able to reach out to them to increase screening on that. So very dynamic approach to monitoring and then changing screening behaviors as best as we can.
That's terrific.
And if I can
I'd
add one more.
like to put in a plug for the extensive team of our Duke Community Outreach and Engagement team, who are out in our community throughout our catchment area every single day, doing educational programs and doing community-facing navigation and helping people overcome their fears and their barriers to getting to our front door, whether it's for screening or treatment or any other aspect of cancer care. Alicia, a question for you. How do you manage weight gain in the survivorship period, especially for the estrogen sensitive type of breast cancer?
That's a great question. I think many people experience weight gain through the course of their treatment, and it can be really a very overwhelming thing to manage when you're going through cancer care and everything that comes with that. We lean a lot on our nutritionists to help us with this, but a plant-based diet is always, kind of a good thing, and in combination with some form of activity and exercise. I typically recommend to my patients to consider like the Live Strong program, which offers a exercise program for cancer survivors that's led by a fitness trainer. So I think that's really important too, because when you're resuming some sort of activity after being deconditioned from treatment, you need to make sure that you don't injure yourself.
And we also have an an exercise physiologist dedicated to the DCI who can provide that individualized assessments and consultation and provide a tailored recommendations and program for our patients.
Dr. Corbett, a very specific question for you. Are your support groups open to non-Duke patients?
Yes, we offer a lot of different support groups, and many of our support groups actually aren't available otherwise in the community. And now what we've learned through telehealth is that we can provide these safely and have increased access to these important groups, not just for Duke patients, but our community as well. So our support groups, most of them are actually open to the wider community.
Okay. And Dr. Anders, in regards to metastatic breast cancer, I've been hearing about NED, no evidence of disease. What is the difference between NED and remission?
Oh, that's a great question. So in some cases, when therapy is highly effective, cancer on imaging, such as our CAT scans and our bone scans and x-rays, is no longer visible. And so that's what we would term no evidence of disease. So we can't see evidence of disease on the radiographic imaging. You know, I think that does not necessarily equal remission, depending on the definition of remission. When I think of remission, I think of cancer being gone. I think the problem with our imaging is we aren't good enough yet to see individual cells in circulation in the bloodstream. So believe me, I love no evidence of disease. We congratulate that. But I think what that means is that the burden of disease is low, the therapy's working, and we want to keep that therapy going to keep things under good control. As long as it's not negatively impacting an individual's quality of life or causing toxicities, because we don't want to give symptoms beyond the symptoms of the cancer. So that's a really delicate balance, and that's a conversation to have with your medical oncologist to ensure that the balance is in the right direction.
Thank you. So I'm going to wrap things up with one last question, and I'd like to start with Alicia, because as a nurse navigator, she sees the whole continuum. And it's a little bit of a challenging question, so do your best. And it's just simply this. What two things would you tell a person who just learned of their cancer diagnosis?
Oh, that is a good question. That's a tough question. You know, typically when I meet someone for the first time, or I'm talking to them on the phone and they're coming into our system, I first just tell them, let us be your support. We're going to hold your hand. We're going to help you get through this. We're going to navigate it. And we're going to make this as easy as possible and resource you with all of the things. Just communicate with us and ask all of the questions, write your questions down, and really just talk to us about the things that you're feeling so that we can help alleviate the anxieties.
Dr. Effinger.
A tough one, having been through a lot of cancer through our family. I think following up with Alicia, the number one thing is we're there with you. We're there with you through your journey, whether that's a journey that's short or a journey that's very long. We're there with you. Second thing is, I think it's important for us as providers to be very real, not to have rose color glasses, nor to be fatalistic or pessimistic, but to really be real and say, here's what we think we can do. Here's generally what can happen. And there's always exceptions. And it's important to keep hope even when things look grim.
Dr. Anders.
So the other thing, well, those are all fantastic points, and I echo each of them. The other thing I really try to emphasize at a brand new cancer diagnosis is that we need to get to the plan. And many times getting to the plan, 2 to 3 weeks can feel like an eternity. So I really try to indicate that we're in the marathon, not the sprint. And getting to that plan and knowing what direction we're going in is really important. So I think that many times can help in what can be a really dark time. And just to know that we will get there together, just as Alicia said, and it may take a couple weeks, but we want to get it right. And we're not going to do anything that's not, each cancer type has a different time frame. And so what might look one way for an acute leukemia diagnosis might look very different for a metastatic breast cancer diagnosis or another solid tumor type. So really just getting to that plan and then working that plan together. And just like Dr. Effinger said, we're going to be there every step of the way.
And Dr. Corbett, you have the last word.
Oh gosh. So I guess I would echo everybody to say you're not alone. You do have a community of support here by your side. And the other piece of that, I think that's really critical is about communication. This is such a scary, complex journey that people are on, and we don't expect people to understand everything we're saying, feel great about everything. We want people to be able to communicate questions, concerns. If they're not sure what the treatment plan entails or what it means, ask those questions. We want people to feel comfortable doing that. So I think communication is really important with your care team and with your loved ones, because you're all going through this together. So those would be two things that I would say in terms of that we want to make sure people know in terms of the care that they receive at DCI and what we would hope for them.
Well, thank you. And I want to just express my gratitude to our distinguished panelists for sharing their knowledge and their experience today. I've learned things today that I didn't know, despite having been in the cancer field for over 40 years now. And I'm very grateful that you've taken time to share with our survivors and the people online today. And let me thank you all who are on this Zoom webinar today for joining us. And I want to encourage you to take advantage of the remaining offerings throughout Survivorship Day. Our recordings will be available on the Survivorship Day site, so you'll be able to go back to them. And please remember that our services are available to you and your family from the suspicion of diagnosis through survivorship. And as you heard all of our panelists say today, you are not alone. We will be standing with you on your whole journey. Thanks, everyone.